Good morning, good afternoon. My name is Dr. Nicholas Chen, and I am an addiction medicine fellow and emergency medicine physician at Rush University Medical Center. And today we will be discussing the prevention and treatment of opioid overdose using naloxone. I do not have any disclosures, and here are some learning objectives. We'll first review the epidemiology and risk factors associated with opioid overdose. We'll recognize signs of opioid overdose. We'll learn to respond and treat an opioid overdose. We'll review local laws regarding opioid overdose and treatment and describe rationale for overdose education and naloxone distribution. So to begin, let's take a look at this brief video by Dr. Sanjay Gupta on opioid overdose and the use of naloxone.
Today I want to talk about a medicine that some people say could help stop this epidemic, but only if we get it in the hands of more people, not just doctors, but average people as well. Now look, it's controversial, but you're about to see this incredible video showing how it might work. What you're looking at is pretty shocking. A heroin addict overdoses. Her name is Liz. She's been using drugs since she was 11. Today, she's 29. Adam Wigglesworth and Louise Vincent were both with her that night in August. They both volunteer with a program in Greensboro, North Carolina that provides clean needles and other assistance to addicts.
She seemed to be pretty unresponsive, and we were noticing a bluing of the lips, lack of oxygen, so her breathing became quite shallow.
Well, once someone's not breathing and they're not responding to any sort of stimulus, you give them breath, and at that time, I usually administer naloxone.
Now watch what happens next.
We gave her about 60 units of Narcan.
Narcan, also known as naloxone, can reverse an overdose from heroin and other drugs, like oxycodone. Another sternal rub, another shot of Narcan.
All right, let's go ahead and give her some more Narcan.
Giving her the rest of the full CC.
And finally, Liz begins to come to.
Liz, you okay? You went out. We're giving you mouth-to-mouth resuscitation. We're giving you some Narcan. This is overdose. Can you sit up? All right, come on.
When someone takes heroin, the drug locks onto receptors in the brain. It slows the body down. Lock up too many, and you stop breathing. Naloxone can free up those receptors, essentially bringing you back to life. You might wonder, that video of Liz, is that real? Well, we showed it to 4 emergency room doctors who all said, yes, this is what a recovery with Narcan looks like.
I can't believe that somebody cared about me enough or, loved me enough to bring me back.
Back to right a life that somehow went wrong. We met Liz on the day she checked into rehab, packing up her things, taking another look at the album of her 19-month-old daughter.
I had felt so separated and just disassociated from my daughter because I felt like, basically like I wasn't good enough to take care of her. I can't finish school. I can't hold down a job. I can't, do any of this normal stuff that everyday people have absolutely no problem. It's not a challenge for them.
Naloxone gave Liz a second chance.
So I think this video depicts not only some signs of opioid overdose and depicts how naloxone can work to save a life, but it offers a glimpse of how debilitating and life-threatening opioid addiction can be, and that people suffering from opioid addiction are humans with family, with jobs, with a sense of belonging, a sense of meaning and purpose in their life, and often commonly have a history of trauma or emotional or physical pain, which they are using substances to cope. No one with addiction ever wanted addiction. So some context of opioid overdose. The number one cause of unintentional death in the United States is death from drug overdose. This is followed by death from motor vehicle accidents and death from unintentional falls. Currently, synthetic opioids are the main driver of drug overdose deaths in America. The majority of opioid overdoses occur in the presence of witnesses. There exist many barriers to medical care in patients who use opioids or substances, such as fear of legal consequences and the belief that they can self-manage their symptoms and overdose without medical assistance. Witnesses often take ineffective action. Persons at high risk of overdose are likely to witness more overdoses, and these are great targets for overdose training, education, and to arm them with naloxone. So what is an opioid and what is an opiate? Opioid is the broad category of any compound that attaches to the opioid receptor, and that includes the opiates. Opiates are just derived natural forms that come from the opium poppy plant. And so opioids is the global broader term, and that includes the opiates, semi-synthetic opioids, and synthetic opioids that are listed there. In America, we have seen 3 waves in opioid overdose deaths. The first wave began with increased prescribing of opioids in the 1990s, with overdose deaths involving prescription opioids. These include natural and semi-synthetic opioids that we had saw on the last slide, in addition to methadone. And the second wave began in 2010 with rapid increase in overdose deaths involving heroin. The third wave began in 2013 with significant increases in overdose deaths involving synthetic opioids, particularly those involving illicitly manufactured fentanyl. The market for illicitly manufactured fentanyl continues to change, and it can be found in combination with heroin, counterfeit pills, and even cocaine. Again, this is another depiction of just the different drug types and use over time as they are associated with drug overdose. As you can see, we are in an epidemic of synthetic opioid overdoses causing deaths. But this chart also notes, this graph notes that there are other drugs of misuse that have increased over time that have been associated with drug overdose deaths, such as cocaine, prescription opioids have had a wave and then a subsequent decline over the last couple of years. But we see that cocaine and other psychostimulants have increased, such as methamphetamine. Use of benzos have gone up and kind of plateaued and decreased somewhat. National drug overdose deaths involving prescription opioids have overall had a couple peaks over the last 10 years and are overall in the decline when they're associated with deaths. However, prescription opioids in conjunction with synthetic opioids have increased over time, especially in the last 5 to 10 years. Drug overdose deaths involving heroin had a peak in about 2015, 2016, and had a subsequent decrease when looking at heroin alone. However, heroin in conjunction with synthetic opioids have increased over the last 10 years. And this is looking at benzodiazepines with opioids. And we see that the combination of benzodiazepines, in addition to synthetic or non-synthetic opioids, have increased and are causing overdose deaths. This slide looks at Cook County overdoses, and we saw a sharp increase in opioid overdose deaths during the COVID-19 pandemic. Not only are we still tackling issues with housing, access to care, and access to addiction services, but this is all occurring during a national pandemic, health disaster. We note that in Cook County and in Chicago, there have been racial disparities in opioid overdose deaths, with non-Hispanic Blacks really showing the most amount of opioid overdose deaths, followed by non-Hispanic whites and Hispanic and Latinx populations. However, nationally, we do see a contrast, and that overdose death rates overall are highest among non-Hispanic whites. However, drug overdose deaths are rising the fastest among non-Hispanic Blacks. This is national drug overdoses during COVID-19. This was released by the CDC. The increase in drug overdose deaths appear to have accelerated during the COVID-19 pandemic. Approximately 81,230 drug overdose deaths occurred in the United States in the 12 months ending in May 2020. And this was the largest number of drug overdose deaths for a 12-month period ever recorded in US history. So we have a very big problem, and the problem is worsening and has recently accelerated during COVID-19. Synthetic opioids are the primary driver of the increase in overdose deaths. And state and local health departments report the increase in synthetic opioids involved overdose is primarily linked to illicitly manufactured fentanyl. The CDC did make some recommendations in response to this information that was released, and their very first recommendation was to expand the provision and use of naloxone and overdose prevention education. So this is why this is all important and relevant to our current times. This was something that I had found at one of my emergency ER sites that I work at. And this is a depiction of what we call bags of heroin that are purchased illicitly on the street. And each bag is about 0.1 milligrams and has a street value of $10 per bag. This is obviously more than 10 bags and has a lot of potential to harm an individual. Risk factors for a drug overdose. Let's talk about drugs themselves, okay? Routes of use are important to note, and with intravenous drug use posing a higher risk for overdose, combining drugs such as using opioids with benzodiazepines or alcohol, increased potency such as synthetic fentanyl, and changes in drug supply, as we know that there have been laced heroin and laced opioids, in addition to fentanyl being mixed in other types of drugs that people are purchasing that are non-opioids. Tolerance is a risk factor for overdose, particularly when there is a loss of tolerance. So what is tolerance? It is when there is excessive and prolonged use of a substance, which leads to the need for increasing amounts of the product to have the same effect. Abstinence decreases tolerance and increases overdose risk. Abstinence can occur in the short term or long term during incarceration, hospitalization, drug treatment, detox, sporadic patterns of drug use, and are risk factors for overdose after that period of abstinence. However, as tolerance increases, so does the need and amount of the drug to achieve continued effects. Because the body is unable to manage this quantity over time, a threshold is breached and an overdose can occur. Using alone is another risk factor for drug overdose, and this is something that you should educate and encourage patients not to do. History of substance use disorder or overdose, or history of overdose, is a risk factor. Unstable housing or finance is a risk factor, and physical and mental illness is a risk factor. Nearly 80% of those who had experienced a previous opioid overdose reported witnessing an overdose. And so these are, again, our good target populations to really be educating and empowering the use of naloxone. We've seen an increase in potency in the drug supply, and this graph is depicting the amount of naloxone that is being administered by EMS for opioid overdoses over time. And what we see is that EMS and pre-hospital providers are requiring higher amounts of naloxone to treat opioid overdoses, reflecting the increases in potency in the drugs themselves. Decreased tolerance. So this was a cohort study of 76,208 prisoners that were released from the Washington State Department of Corrections between 1999 and 2009. The mean length of follow-up in the study was 4.5 years, and the leading cause of death in former prisoners was drug overdose. Pharmaceutical opioids were the most common substances involved in their deaths. We also found, the study also found that multiple substances, often in conjunction with opioids, were involved in more than half of substance-related deaths, and that women leaving prison were at higher risk for opioid-related death than men. Mixing drugs. In 2018, the New York City released their drug poisoning overdose deaths, and opioids were involved in 80% of their deaths. And half of the overdoses involved other CNS depressants in addition to opioids, such as alcohol and benzodiazepines. take a look at this video that captures an heroin overdose on a public bus, and just take note of the public's response to the situation, and let's take a look at this.
The video shows 25-year-old Michael Meany shooting heroin into his arm while riding on a crowded bus at 1 o'clock in the afternoon. Meany starts to nod off, falls out of his seat, the result of an overdose. Officers arrived at the scene. They used Narcan spray. It's a heroin antidote to save Meany's life. He was escorted out of the bus and taken to a hospital.
So as you can see, those were some of the signs of an opioid overdose, starting with some nodding off and falling out of the chair, but that no one around him really was able to assess the situation or respond to it. And, essentially EMS were the first to provide naloxone in this situation. This depicts somewhat of a lack of awareness and lack of education in understanding what opioid overdose is and potential treatment options.
The video shows 25-year-old Michael Meany shooting.
So how does an opioid overdose work? There are multiple different opioid receptors through the body. The three main types are the mu, the delta, and the kappa receptors, and they're primarily located in the central nervous system and the extension off the central nervous system, which is the gut. We won't go into exactly the details of each receptor, but I've listed their clinical effects here for your reference. This is a opioid side effect handout that was created by Stanford Healthcare, and it shows the opioid side effects and that they are global and diffuse throughout the human body. Starting with the central nervous system, opioids can lead to decreased cognitive function, drowsiness, sleep dysregulation, tolerance, physical dependence, opioid-induced hyperalgesia. Moving down, we have effects on the pulmonary system, decreased respiratory drive, which is often the cause of accidental overdose, the death associated with accidental overdose. It can lead to decreased cardiac output. It can affect the GI tract and cause constipation and bowel dysfunction. It can affect our sex organs and glands and cause hypogonadism and lowering of sex hormones. It can increase the risk of fractures. So opioids affect more than just the brain and lungs. They do have diverse and global effects on the entire human body. How do we recognize an opioid overdose? I found this mnemonic to be very helpful and very easy to remember, the mnemonic BLUE. Starting with breathing. Is there shallow, erratic, or absent breathing? Look at the lips. Are the lips or fingertips blue? Check for signs of unresponsiveness. Provide verbal or tactile stimuli and assess a response. Is the patient unresponsive? And then take a look at eyes. Eyes, do they have pinpoint or unusually small pupils? Strategies to address opioid overdose. We will be talking about increasing training and access to naloxone. That's kind of the bulk of this lecture, but there are many other ways to address opioid overdose and the epidemic we currently are facing in the United States. And there are many other ways, and we'll talk about that towards the end of the lecture. But increasing access to naloxone, there are many ways. First, we can increase community training and distribution. We can increase prescribing in the emergency department, inpatient and outpatient settings. We can increase access among first responders. And we can collaborate with pharmacies and create policies to better improve access to naloxone. So what is naloxone? Naloxone is an opioid receptor antagonist that works at those receptors we talked about, the mu, kappa, and delta receptors. Naloxone displaces the bound opioids, reversing the effects of overdose. It has no effects in people not using opioids and has no potential for misuse. It reverses respiratory depression, hypotension, sedation that are often the causes of opioid overdose deaths. It was first approved in 1971, and first responders and the general public we're able to then treat suspected opioid overdoses using an improvised nasal naloxone device. We will be showing an example of what that is, but just note that that was used kind of off-label initially in 1971. And then we'll talk about a few of the other different formulations. Its routes can be used predominantly in the pre-hospital setting are intranasal and intramuscular. In the hospital setting, intravenous naloxone is often definitive management. Its onset is about 2 to 3 minutes and duration is about 30 to 90 minutes. In noting that duration, just be aware that overdoses can recur and there may be the need for recurrent and multiple doses of naloxone. Naloxone is metabolized through the liver and excreted through the kidney. It's extensively metabolized in the liver, largely by conjugation with glucuronide, followed by its urinary excretion. Therapy with naloxone has not been linked to any acute or clinically apparent liver injury, and that patients with opioid overdose often have underlying chronic liver disease from alcoholic liver disease, hepatitis B, or hepatitis C, but that treatment with naloxone does not appear to exacerbate those conditions. So prior to September of 2020, there existed 4 types of naloxone preparations. However, in September 2020, Kaleo, the makers of Ivzio, this intramuscular auto-injector, discontinued their product due to the availability of lower cost generic versions or lower cost options. And so as a result, there currently exists 3 types of naloxone preparations. I will be showing you a video that talks about these preparations. As of October 2020, there exist 3 preparations of naloxone that can be used in the community and pre-hospital settings in the United States. 2 of the formulations are intranasal sprays and 1 of the formulations is intramuscular injection. We will be reviewing the 3 types of naloxone preparations today. It is important to know that only 1 of the 3 formulations is actually FDA approved, and that is the 4 milligram intranasal spray. The first formulation of naloxone that we will be reviewing today is the intramuscular naloxone injection. The intramuscular naloxone injection typically comes in a pre-filled kit that contains 2 sterile syringes and 2 doses of medications. Each sterile syringe in this kit is 3 cc's, 23 gauge with a 1-inch needle tip. Each dose of naloxone is 0.4 milligrams of naloxone in 1 milliliter of solution. To use this medication, you first remove the yellow cap off the vial of medication. Next, you take your sterile syringe, remove the needle cover, and draw up 1 cc and the full dose of medication. You remove any excess air, and the medication is ready to use. To use intramuscular naloxone, you insert the needle 90 degrees to the skin surface in the upper arm or thigh. It is important to know that you can inject through clothing and that alcohol swabs to clean the vial or to clean the site is not required. Some advantages of intramuscular naloxone is the low cost. Some disadvantages are the chance of needle sticks and transmission of infectious diseases. After administering the first dose of naloxone, you will wait 2 to 3 minutes for a response. If there is no response, you can administer the second dose of intramuscular naloxone. The second formulation of naloxone that we will be reviewing today is the FDA-approved intranasal spray. The FDA-approved intranasal spray was approved in November 2015, and it looks like this. To use the spray, you remove the outer packaging, which reveals the intranasal device. The device contains 4 milligrams of naloxone constituted in 0.1 milliliters of solution. To use the device, you stabilize the device with your index and third finger and use your thumb to then administer the medication. To use the medication, you first check for any obstruction in the nose. You'll block off one of the nostrils and then you'll insert the device into one nostril and use your thumb to depress the plunger. The final formulation of naloxone that we will be reviewing today is the intranasal naloxone atomizer. This is not FDA approved but can be used in the community setting. Each box looks like this, and each box contains a pre-filled syringe of 2 milliliters that contains 2 milligrams of naloxone and a mucosal atomizing device. To use this medication, you connect the pre-filled syringe to the atomizer, twist it, and it's ready to use. You will need a separate component, which is the atomizer in itself, and that screws onto the tip, and the medication is ready to use. Unlike the FDA-approved intranasal spray, the intranasal naloxone atomizer must be used in both nostrils, 1 milliliter each. Again, you will check for any obstruction, you will cover one nair, and you will inject 1 milliliter in each nostril. That is how the atomizer works. So there were 3 preparations. Those were the 3 preparations of naloxone. Just to recap, there's 2 intranasals and 1 intramuscular. The improvised nasal naloxone device, which was the last formulation that we reviewed, was the one that was been used since 1971. It does come in the 2 milliliters of solution, and 1 milliliter has to go into each nostril. In 2015, that is when the 4 milligram intranasal spray was approved, and that is the only FDA-approved naloxone. And that is the 4 milligrams constituted in 0.1 milliliters. So it's a much higher, much more concentrated solution and a much smaller volume to be administered in the nose. The 4 milligram intranasal spray has been more effective than the improvised intranasal atomizer. The intranasal formulation reduces risks of needle sticks and disease transmissions and are commonly used. Intramuscular does have better bioavailability. It's cheaper and has more rapid onset compared to intranasal formulations. And those studies are somewhat limited in terms of its bioavailability. IV naloxone is the definitive treatment for opioid overdose, and it is important to remember that these naloxone preparations that are being used in the community and pre-hospital settings are not substitutes for emergency medical care. These are slides for your reference that talks about the 3 types of naloxone preparations that we reviewed. We will not be discussing these slides, but they're here for your reference. Responding to an opioid overdose. So first, before we even engage with assessment of an individual that may have overdosed, you should assess the scene and prioritize your safety. Next, try to wake the person up. Provide tactile, provide verbal stimuli. If they are unresponsive and not responding, call 911. Remember, this is definitive care, okay? Persons can overdose on multiple substances, and naloxone may only work for just opioids. In addition, opioid overdoses can recur after naloxone wears off, so you need to get this individual to the hospital. You can then check for breathing, clear the blocked airways, and check for any airway obstruction. Administer naloxone, and you can repeat doses every 2 to 3 minutes if there is no response. And there's no limit to how many doses that you can give. You should stay with the person until ambulance arrives, and once breathing independently, place them in a recovery position. What is recovery position? This is recovery position. It's a means of supporting their airway and preventing aspiration and allowing the patient to really just wait for further medical care. You should stay with the person until ambulance arrives, and note that naloxone can precipitate withdrawal symptoms. So if this happens, you should calmly explain the situation to the person. Naloxone, like any other drug, has an expiration date. In the case of an emergency, you can still give the expired naloxone if that is all you have on hand. It may not be as effective as an unexpired product, but it is better to give naloxone than to withhold it from the patient. If you have an unexpired product and an expired one, give the unexpired product first and use the expired one as a backup if necessary. Here are some written steps for the recovery position, but I think the picture is worth 1,000 words. Why should you carry naloxone? It's a safe, cost-effective way to save lives in the event of an overdose, particularly during an opioid epidemic. It is non-toxic, it has no psychoactive, addictive, or euphoric properties. It has shown safety in use in pregnant women, children, and even animals. Family, friends, first responders, all lay people can be taught to recognize an overdose and administer naloxone during an overdose emergency. Naloxone distribution has been endorsed by the American Medical Association, the Substance Use and Mental Health Services Administration, the National Institute on Drug Abuse, and many others. Research shows that when naloxone is distributed in communities, it can reduce overdose deaths by 50%. So now that we talked about naloxone, let's talk about other strategies to address overdose. Another strategy is looking at a prescription monitoring program. They are often seamlessly integrated now in electronic health record systems, which removes the need for the user to log into the website. However, some caveats are that sometimes those electronic health records are not importing the full data, and there can be errors with regards to the patient's name or date of birth as a way that they are kind of pulling in that data. So I recommend that even if you're not prescribing controlled substances, that you make an account with Illinois PMP if you're a provider, and screen your patients and check up PMP, particularly if you have any concerns for overdose risk or if your patients are receiving any kind of controlled substance. And the PMP can note not only if they are receiving prescription opioids or the number of providers that are providing prescriptions to them, but it can also show treatment such as buprenorphine. Methadone will not be shown on the prescription monitoring program. So it's another good way to assess if patients have been in treatment before and if there are any local providers that are providing buprenorphine or to the patient. The CDC, so Safe Opioid Prescribing Guidelines. The CDC did provide some guidelines for prescribing opioids for chronic pain. And there were a couple sections and domains that they looked at, but in summary, there's a few that I will list. And some of their guidelines were: 1, to evaluate for risk factors, those risk factors that we talked about. Remember those things, ask patients about those things. 2, recommend naloxone if there's a history of substance use disorder, if they have a history of overdose, if opioid doses are being provided in greater than 50 morphine milliequivalent oral morphine equivalences daily, and if there's any concurrent benzodiazepine use. Essentially, you should have a low threshold to prescribe naloxone. You should be reviewing the prescription monitoring program. You can obtain a urine drug screen prior to prescribing opioids. Should avoid any concomitant opioid and benzodiazepine prescription, as that increases the risk of overdose. And you should offer treatment for substance use disorders. Another strategy to address opioid overdose is to screen and to treat opioid use disorder. This is just a slide that depicts 2 types of treatment for opioid use disorder, one being methadone, the other being buprenorphine. The graph on the left looks at patients' opioid use while they were receiving treatment with methadone, and those control subjects who are not receiving methadone. And they showed that there was overall decreased opioid use amongst multiple studies when patients were on methadone. This graph on the right looks at buprenorphine versus patients who were started on buprenorphine versus patients who were not, and looking at their engagement in treatment at 1 year. And as you can see, people that were not on any kind of, or not being treated with buprenorphine, almost all their patients had fallen out by just over 50 days in their recovery. But patients that were on buprenorphine were able to engage in recovery up to 1 year. And there was a large portion of them that stayed in treatment. There's other medications beyond buprenorphine and methadone, and this is XR naltrexone, which is Vivitrol. It's a extended release naltrexone. It does not provide any opioid agonism. It is purely just preventing opioids from working and more of an abstinence-based approach. And this shows the retention rates at 12 months. Treatment without medications has less than 10% retention rate at 12 months. So medications do work, and you should be screening and you should be offering treatment for patients that you've identified with an opioid use disorder. Other strategies to address opioid overdose: prescription drug take-back programs. These are prescription drugs, they are safe storage and disposal units for prescription drugs and allows patients to return unused opioids or other prescriptions. They can be found at many pharmacies, and you should be checking with your community and local institution about where these are located and be referring patients to these patients who receive controlled substances to these sites. It is sponsored by the DEA. Supervised injection facilities. There currently exists none of these in the United States, but let's take a look at what was implemented in North America and Canada, in Vancouver particularly. This is Insight, is what the name of the injection supervised drug injection facilities called. And what they found was that they reported a 35% decrease in the number of lethal overdoses in the area after opening. And that since Insight opened its doors in 2003, there has not been a single fatal overdose on its premise. The first injection site globally was in Switzerland, and there's about 100 sites worldwide currently. From a public health perspective, it's shown to reduce overdose deaths, fatalities, and decrease the spread of HIV and hepatitis C. It also has shown to increase entry into treatment, and Insight does offer linkage to treatment at their facilities. There's less litter, needles, and for public safety, in a public safety perspective. And from a cost savings perspective, it has shown to opening these supervised drug injection facilities has shown to have associated savings in HIV-related medical care costs that have been sufficient to offset their operating costs of these facilities. Lastly, another strategy to address overdose is legislative responses. So Illinois law has developed over time to protect laypersons, providers, and people who are using drugs from obtaining and using this life-saving drug naloxone. In January 2010, the Drug Overdose Prevention Program was started and stated that anyone with training can administer naloxone and is immune from criminal prosecution. Stated that healthcare professionals prescribing and dispensing naloxone are not subject to any adverse actions. And it also provided grant funding for overdose prevention, education, and naloxone distribution. In June of 2012, the Good Samaritan Law was released, and this stated that people seeking emergency medical assistance for themselves or another individual experiencing overdose are immune from criminal prosecution of drug possession. In September of 2015, the Heroin Crisis Act, also known as Lawley's Law, came into play. And this was essentially an Illinois naloxone standing order in which retail pharmacies can dispense naloxone without a prescription. Pharmacists who are dispensing naloxone are also protected from disciplinary action. However, due to stigma associated with opioid misuse, patients may be reluctant to ask for naloxone at the pharmacy. So providers can still write or send a prescription for patients to pick up. These are some of the local community sites in Chicago that provide naloxone for free and also provide treatment and therapy for opioid use disorder and other substance-related use disorders. This study essentially showed that family members that were not prescribed opioids are at a 2-time increased risk of overdose by just having a prescription of opioids in the home. So very important that not only do you let patients know about their risk for opioid overdose, but that their family members are at risk and that their family members should be aware of the risks associated with having the opioid prescription at home. And they should also be educated and informed about how and when to use naloxone. So some counseling tips. First, you should ask what the patient knows about naloxone. Use open-ended questions such as, what kind of concerns do you have? What questions do you have about this medicine? What do you know about this medicine? Patients might be unaware of their risks of overdose. Review risk factors for opioid overdose, as we talked about. Review the signs of an opioid overdose. Emphasize that naloxone is a temporizing measure and that definitive care is 911. Discuss that patients are unlikely to use naloxone on themselves, so you should educate them and counsel them that it's important to keep it on you so that someone else can use it on you. And because of this, you should encourage patients to discuss naloxone with their families, friends, or people that are close to them, or people that are using drugs with them. Use simple and non-stigmatizing language. The words we use as healthcare professionals frames illness, shapes medical judgment, and can cloud understanding and perpetuate social biases. Words can have long-lasting implications on patients. When these terms enter the public arena, they convey social norms and attitudes. Physicians and healthcare professionals should strive to use language that accurately reflects science, promotes evidence-based treatment, and demonstrates respect for patients. Terms such as drug addict, drug abuser, clean or dirty urine drug screens, treatment failure, being clean are commonly used in the medical setting. However, terms such as people who use opioids or people with an opioid use disorder, a negative or a positive urine drug screen, treatment attempts rather than treatment failures. And instead of using terms such as being clean, you can use terms such as patients who are engaging in recovery. We should try ourselves and educate others to avoid terms that further stigmatize opioid use disorder and naloxone and have long-lasting implications on a patient. I've had patients tell me that that they read their discharge papers or they get their discharge papers and they see across multiple institutions that they are identified as a 35-year-old male or female with a history of intravenous drug use. And that's the first thing that identifies them and sticks with them throughout their life. Or a 35-year-old male or female drug abuser. So it's really important to really reframe how we perceive these types of patients in terms of a chronic disease and illness, and reframe the words that we use to describe these patients. Overall, we should have a low threshold to provide naloxone education to patients with risk factors for overdose. Naloxone education and distribution saves lives, and it addresses a national public health crisis. Again, drug overdose is the #1 cause of unintentional death in the United States. Illinois helpline for opioids or other substances is listed here. It's 1-833-2-FIND-HELP, easy to remember, and something that you can offer your patients. These are the listed references for this talk, and I appreciate you spending the time to listen. And if you have any questions, you can always contact me, and hope you all have learned something and feel more empowered to discuss naloxone and prescribe naloxone after this lecture. Thank you for your time.